Hi, I'm Emily Field. I'm an evaluation specialist at USET. Like Brian said, in order to get continuing education units, please follow the link. You will first have a quick survey that'll just ask you for contact information for the continuing education credits, and then the next page will link you to an anonymous survey. Please feel free to be as open as you'd like in giving us feedback. We really want to know how we can improve these sessions. This session is being recorded and will be posted on our YouTube channel following today. And please mute yourselves if you haven't already done so, and feel free to ask questions throughout. You can ask in the chat to everybody, or you can ask to one of us and we'll ask for you. Thank you.
Thank you, Emily. And we'll go ahead and get started with Amani Ransby.
Hi, good afternoon, everyone, and thanks for joining us for today's ECHO session. I will be giving our usual update on the COVID-19 epidemiology in the Nashville area region, as Brian mentioned, and this will just include taking a look at some of the data points that are currently included in our USET aggregate surveillance report. A reminder, this is sent out weekly on Tuesdays to our member tribal nations as well as USET staff. And I do also want to mention that we have updated this report to include an additional attachment to show the USET states combined, the rate of COVID-19 cases that we're seeing combined in our region, as well as a breakdown of each state. So you will notice that those reports have been updated some to include that information as well. So the current slide shows you the number of new positive test results, the cumulative total of positive test results, as well as a 7-day positivity rate, or the percent positivity, for the past week of January 18th to the 25th. And so for this week, the number of positive COVID-19 tests at reporting facilities in the Indian Health Service, or IHS Nashville area, in the last week was at 229, while the cumulative total of positive COVID-19 tests was at 5,149. And then the 7-day positivity rate at 12.9% here. And so just a reminder as well that these numbers were obtained from the 27 sites that are currently reporting COVID-19 testing data to IHS. And also for those that are not familiar with the percent positivity, it can be a pretty useful data point in tracking increases in the overall number of positive test results over time, which would reflect a higher percent. And alternatively, a decrease in that percent would be indicative of having more negative test results. And so it's my hope that we'll see this percent kind of decrease over time now as we've entered into vaccine administration and are continuing public health prevention measures. So the slide displayed on the following graph shows the number of new positive COVID-19 test results from week to week over a 12-week period. As I mentioned before, for the week of January 18th to the 25th, this past week, the number of new positives in the USET region was at 229. This was a significant decrease from the previous week as reflected on the graph. And so the peak that you see from January 4th to the 11th was likely attributed to transmission that occurred during the recent winter holiday, as we were also seeing some tremendous increases in the number of confirmed cases at the national level around that time as well. So in general, we have seen the number of new cases increase over time as the pandemic has progressed, but it does appear that we may have reached a turning point now with the noted decrease in this week's number of new COVID-19 cases. And so we do expect the number of cases to continue to decline at this point in time with vaccine administration, as I said, getting more ramped up now, as well as the continuation of public health prevention measures that have been used to alleviate the transmission of COVID-19 in communities. So this graph displays the rate of COVID-19 cases per 10,000. It's broken down by USET counties, USET states, as well as the United States. A 12-week time frame has also been provided for this information just to kind of better follow the trajectory of the outbreak over time. And please note that this data was obtained from CDC and state health departments, so it is not limited specifically to tribal citizens here. And so we have continued to kind of use the surrounding areas around tribal nations as an indicator for the amount of COVID-19 cases that are being seen within our region, and to kind of just locate where the burden of disease potentially lies. And we found this to be pretty useful throughout. So for this past week, again, of January 18th to the 25th, the purchased and referred care delivery area, or USET county rate, was reported as 46.24 cases per 10,000, while the USET state rate was reported as 40 cases per 10,000. And lastly, the United States rate at 41.57 cases per 10,000. So over the past several weeks, the USET county rate has continued to surpass the USET state rate and the United States rate. For this week specifically, though, the USET county rate, my apologies, was highest, followed by the USET US rate, and lastly, the USET state rate. Please note that the large spike that you're seeing in the USET per rate reflected for the week of December 21st to the 28th. It was expected, although we did not expect to see that much of an increase in the number of positive cases during that time. So the magnitude of that spike may likely be attributed to data cleaning and or the initial miscoding of county of residence. So I just wanted to make note of that. And as seen with the data obtained from our sites on the other graph we just reviewed, the rates, as I said, are now beginning to decrease across the board, with the USET county rate and state rates both decreasing from the previous week of January 1st to the 18th. Although it is noted that the USET county rate has continued to demonstrate the presence of widespread COVID-19 infections at the county level more than that of the state or national level, as it is the highest of the three. So we are still offering the red cap accounts for COVID-19 related tracking, whether this is to track the cases within your community, and now more relevant, perhaps vaccine side effects. So if you are interested in getting a red cap account, please feel free to reach out to us. Or if you require general assistance, also please feel free to reach out to us. And that would be at usetepi@usetinc.org. Thank you.
Great. Thank you, Amani. Do we have any questions for the Epicenter at this point? If you have any questions, you can type them into the chat or unmute yourself and ask your question. Hearing none, we can go ahead and move on to Janet Medford. And Taloa, if you will, hold on, pull up the PowerPoint.
Okay, first of all, I would also like to recognize Chris McKnight, who is our lead pharmacist in this project as well. And he's going to start the first part of our presentation.
Thank you, Janet. Hey, Dr. Brown asked us to just come provide some, I guess, some of our experience in our vaccine rollout. This is a lot of hands-on sort of lessons learned, tips and tricks that we've discovered in starting this. So while there is some variability in experiences from one location to the other, we think that a lot of this will hold true whenever other service units are trying to roll out the vaccine. If I can get it to go to the next slide, there we go. So rule number one, please don't be scared of this whole process. The vaccination or mass vaccination event are things that we've done in the past, whether it be kindergarten roundup vaccine events or flu shot, community-based flu shot clinics. A lot of the principles are exactly the same. The only difference is the vaccine itself. And I put this picture in here because it's on the surface kind of a boring picture. This is the day that our first shipper of Pfizer came in. It was offloaded from the UPS truck and it was placed in the middle of our supply. But what this picture doesn't show is off to the right and behind the camera person, there's like 10 to 15 people, at least 10 feet away from this thing. Obviously, a bit apprehensive as if it was full of copperheads or something along those lines. And I think that's probably normal or to be expected because, you know, the COVID pandemic as well as vaccine has had so many eyes on it that there's probably some apprehension or nerves associated with it. And I just want to discourage everybody, you know, treat it as you would any other mass vaccination events you've done in the past, flu shot clinic, drive-through flu shot clinic, whatever it may be. A lot of those skills that you develop there are going to apply here too. So I get the next slide. Thank you. So I'm going to talk more about the handling, processing component of the vaccine, and Janet's going to go into the clinic structure setup and operation of it. And I've kind of divided this up in between Pfizer and Moderna, being that there are some administrative differences between the two of them. You're probably wondering why I included two pictures of a shipper. So this is their boost dose shipper, and notice that it's a bit rough around the edges. They are reusing packaging. I'm not exactly sure what sort of assessment they're getting upon return to reissue this. I will note that the boost shipper seemed to retain its temperature just as well as the prime dose shipper did, but I am curious what is needed for them to start pulling them from the market and replacing them as opposed to just reissuing them to the next dose. Dr. Brown, when we actually received our first one, he came down. He's really excited. He wanted to see it. Happy to show it to him. However, if you've ever seen a white cardboard box, you've seen the Pfizer shipper before. There's nothing on the surface that is very special about it, except for it has handles, I guess. But other than that, when you open it up, however, it's about 3 inches of foam insulation around it, and it does have a data logger, which is that middle picture in this slide. Note there's no digital readout on it. It does report through a third-party temperature monitoring system, and you will get daily emails where you can log in and check. This is just one of the printouts here on the right. Check the temperature control. But it does have 3 lights on the top of them. Probably the 2 most important ones are, is it in range? And it'll flash about every 5 seconds, green if it is. And the other one is it connected? Is it transmitting its data so that you can get a digital readout of the temperature? And so it too will flash green with about 5-second frequency. As I said previously, it will give you an email to where you can log into their system and see the temperature logs. That's here on the right. You'll notice it maintains temperature pretty good. Now, we were restocking our shipper with dry ice probably every 3 or 4 days, so more frequently than the 5 that's recommended. And so you see these spikes ever so often. That's where we had to open it to pull vaccine. But notice that really quickly it returned to temperature. And I think the readout on this is, the font's kind of small for, but I think it's 60 to 86, negative 60 to negative 86. So a decent range, but it's kind of amazing that it holds that temperature for as long as it does. Note when you're accessing the shipper, when you pull that vaccine out, you have 3 minutes, which sounds like a short period of time. And to begin with, just to make sure we weren't going over it, we were actually having a third person time ourselves to make sure we weren't going over. Even the first day we opened it and we didn't really have any experience with handling the vaccine, I think that was 2 minutes and 13 seconds. So we never really ran close to it. is the red line at the top mean correct? Yes. So that red line is 60, negative 60 degrees Celsius. At that point, that it's not saying that the vaccine is now capped at the refrigerated 5-day limit. They do encourage you to contact the manufacturer then should it go over it. So if I can get to the next slide. So once you open that box, it's like a Russian doll of boxes, really. So you got the bigger box, and inside that you have a smaller box, and then within that one you have the pizza box, for the lack of a better term. And that's what this is here. This is where the actual vaccines are stored within the shipper. 195 vials per box, per pizza box. So the first time you open it, it's going to be pretty densely packed. And remember, you're wearing thick, like cryo gloves. So dexterity is a limitation. I don't know if you want to have some tweezers there to help you remove the first couple of doses, just to free some space up within the pizza box. But initially, it's kind of tough to get in there with clunky. I mean, I kind of got clunky hands anyway, but add those thick gloves on there, it makes it a bit more difficult to really maneuver. And another thing that we weren't aware of, and it kind of took us for a surprise, like I said, the first time we opened it, a bit nervous. You got 3 minutes. You have to get in and get out. So we had a third person timing us. We open it, we pull this out, and you can't see my cursor, but there are 2 bands that run lengthwise on this box that you actually have to have a pair of scissors to cut off in order to access that. We didn't know that, so we scrambled for scissors a little bit. As well, that label you see wraps around the corner of the box. It's cut in this picture here, but whenever you first access it, you're unaware of that. So a couple things that set us behind and wish we would have knew prior to opening it to begin with, just so we could have been a bit more prepared, but things to consider. If I can get you to, oh, and a third thing to consider, right there where that box popped up, if you're using VAMs to log vaccine administration, so the CDC vaccine administration and management software, I think is what it stands for, you will need both the unit of use lot number, which is printed on all the vials, as well as the unit of sale lot number. If I can get you to advance the slide one more, which is only printed on the pizza box. So remember, you can only access this thing twice a day. You can only have it open for 3 minutes per, and then it must be closed for 2 hours in between openings. So if you don't get this picture at the very beginning, if you don't get this unit of sale at the very beginning, you got to wait at least 2 hours to access it next time. And this was not released the first time we pulled vaccine, which kind of led to a bit of an issue. We just simply delayed logging vaccines until we got the unit of sale and could log inventory in the VAM system. If you're using EHR and RPMS, that number is not needed. You just need the unit of use lot number, which is on each vial. So we get you to go to the next one. So changing over to the Moderna, real quick question. What is missing from this box? And I'll pause as if someone's going to answer, but I'm sure no one wants to unmute themselves. So if I can get you to advance it, there is no expiration date on Moderna. You have to go on their site, log in, type in the lot number, and it will tell you the expiration date. I'm not exactly sure why they did it this way. Seems a bit non-committal to me, but it is not printed on the box, nor is it on the vial. You have to log into their system, and not log in. You just go to their system, type the lot number in, and it'll tell you the expiration. So whenever you're logging inventory through VAMs or EHR, you have to complete this step first. Other than that, Moderna is like every other frozen vaccine as far as storage needs, MMR, Olzoster vaccine, things like that. So nothing too specialized. It's frozen, obviously. So we wish it would just be refrigerated temperature. It is stable with 30 days of refrigerated temperature, but in order to get that longer expiration date, it's frozen, but a lot less handling issues with it compared to the Pfizer vaccine. Next slide, please. Each box you get, both the prime and the boost dose, or the first and second dose of vaccines, will come with an ancillary supply kit, and it's about as turnkey as I think you can expect it. It has a lot of the needs that you would have for a vaccine clinic. I will say, with the first box, they did send us non-compatible syringes and needles, which was a bit interesting. And upon further questioning, it seems like that was a lot of sites. They received the Integra syringes, but no corresponding needles to go along with that. So that was a bit of frustration. Thankfully, we made a point of having redundancy on hand prior to doing this, so it didn't set us back. But just something, yeah, it was with the first box, and we haven't seen it since. So hopefully that's out of there. That kinks out of the line, but just something to be aware of. If I can get you to go to the next. So this is just the list of what's actually in each ancillary kit. And you'll notice they're different. So Pfizer's coming with 195 vials, and Moderna's coming with 10 vials or 100 doses per box. And so with each one, you'll get these kits. So like I said, a lot of the needs are included, but I do want to highlight one thing. If I can hit you next arrow, please. It comes with almost the specific number of cards you will need. So you see here vaccine cards, which is just the little card you write out what dose and lot the patient got, and you can put on there their second appointment date, just so they know when to come back. And Moderna likewise has 100 cards on it. So if I can get you to hit the next. All right, another pop quiz for everybody. So you dilute the Pfizer vaccine with 1.8 mLs. Each shot is 0.3 mL. So how many shots should you get? And let me get next arrow. Yeah, so they told us 5 to begin with, and anyone with a calculator immediately questions that. And like the first day we started, this was before the FDA provided any guidance on pulling a 6th dose or potentially a 7th dose out of it. I'll say conservatively, the constituted vaccine is 0.2 mLs. So some people report getting the 7th dose. I don't believe that as much, but a 6th is very doable. But we started vaccinating before they provided those recommendations that the 6th is viable. And my main concern was auditing of inventory levels. So if we're pulling a 6th dose and we only reported that we got 975 vaccines, what are they going to do when we administered significantly more? Thankfully, if I can get you to hit the next arrow, thankfully the very next day the FDA said, hey, if you can get more out of a vial, do it. So we weren't having to waste doses for too long prior to us being comfortable pulling that 6th dose. Some are reporting that Moderna, you can get 11 out. Not with any regularity, not as regularly as you can with the Pfizer. And I will say with Pfizer, it really depends on your supplies. So if you have the Vantage Point syringes and needles, you can get 6 pretty much all the time. If you're using TB syringes, there's a bit more dead volume in them, so it's a little more difficult to get that 6th dose. But yeah, I guess someone just asked that just then. So the Vantage Points seem to be more reliable, or any lure lock set seems to be more reliable in doing it. Next slide, please. So a couple things to consider are probably good to have on hand that do not come in the ancillary kits. Gloves, obviously, hand sanitizer, of course. It doesn't come with sharps containers. You probably want those as well. And bandages, if you should choose. These are 25 gauge needles. We haven't really had a huge need for them, but it's a shot, and a lot of patients feel more comforted with having a Band-Aid after they get a shot. And I just would recommend having some excess on hand, not the entirety of what you will need, but just something in case, they send you non-compatible syringes and needles. That way you're not delayed too long in trying to get them replaced. So the next step that I want to cover is logging both your inventory as well as vaccinations. We've used about all except for inventory management within EHR and RPMS. The CDC's main requirement is that it's reported to them daily, and thankfully the EHR RPMS patch that pushes that is now available. When we began, it wasn't, so we started in VAMS. VAMS is a very basic system. It's kind of a glorified Microsoft Access database, really. So it doesn't really have any reporting functionality, which if you're doing a massive amount of vaccinations could be kind of a bummer. It's really hard to pull those numbers as well as sort by first, second doses, things along those lines. As soon as EHR was available, we transitioned to that just because EHR has all those reporting functionalities built into it, as well as the scheduling package associated with it and other things that we can kind of pair together to make it a bit more robust. But on the surface, VAMs will do your most basic needs. I would say the higher the volume, the less beneficial it is. I would consider moving to EHR, RPMS, or whichever electronic medical record you use, assuming that it's reported to the CDC. I think it's nightly is when it does its data dump. So, and finally, I continue to maintain a paper log on inventory just because it's easy for everyone to see, but I manage a couple Excel documents that help me both track our prime and boost doses. So your boost doses will come 2, 3, 4 weeks after your prime doses, and they are intended and labeled for boost. It's the same vaccine, but the reason they're sending it to you is to supplement those that have already received their first dose. So it's of importance to keep those separated in your inventory tracking. Like I said, VAMs will do that, but VAMs doesn't. It's very basic. It calculates 5 doses per Pfizer. If you end up getting 6, you have to manually add additional doses to it. So it's not as robust as other systems. Yeah. And some brief scheduling tips, tricks, things that we might not have done as well as we should have. So as you're scheduling up an event, remember that you're going to have to recreate something in 21 to 28 days that is of similar scope to what you're doing. Likewise, remember holidays. So I don't know, I can't speak for Janet, but I forgot about MLK Day. So that led to the Tuesday after us giving a significant chunk of second dose vaccines, just because we had to account for those that would have returned MLK Day. We found it very helpful to get the patients an appointment prior to them leaving from their first dose. So get them on the calendar then. That way, if you can generate reminder letters prior to that week, it helps in them when they leave, if they know when specifically they're to come back for that second dose and where, of course. But know that the first dose is easy to administer because you naturally have a condensed patient load. But as 3 to 4 weeks pass, there will be some scatter. You know, everyone has their personal life. They have varying schedules and calendars. So you cannot ensure that all 100, let's use 100 as an example, all 100 prime doses you gave on a day will be back 4 weeks. So then you might only get 95 of them. Now you have to account for those additional 5. Will they show up on another second dose vaccine day? Then how do you manage your inventory? Will you waste 5 doses of a vial and just have to replace that inventory with prime doses later on? It's kind of difficult. The old saying, herding cats, right? It's really difficult to ensure you have the same efficiency with a second dose as you do with the first, just because life happens for all the patients you vaccinate. So be sure to have enough wiggle room in your inventory to you can accommodate as best you can while still maintaining a degree of efficiency. That's it for me.
Okay, so we wanted Chris to go first because that's how we got things in and where everything starts. So we've been doing our clinics now for 7 weeks. We started with our employees on December the 16th. And so we have learned a few things along the lines. So I'm going to show you how our clinic actually functions right now. And so we'll just go through those steps. So first of all, it's very good to have your registration people out front, your sign-in station. We have the patient sign in and pick up their forms for their registration and screening forms. And they have their computers there to make sure that the people who are showing up are actually on our schedule so that we don't get overwhelmed with too many unexpected people. We all take lunch at the same time. So the clinic closes from 12 to 1 to let us get some lunch, and then we start back. Next slide. So this is what the patients see when they first walk up, the registration area, and then we have some seating area, and we have two people that I call guides, and they they help the person go and sit down in the chairs, and that keeps people from congregating too much. It's been a while since some of them have been out and about, so of course if they're seeing people they haven't seen in a while, they like to stop and talk, but those guides actually take them to a chair and have them sit down, help them fill out the forms if they need help, and they're ready to go whenever they get back to the clinic area. Next slide. So the foundational needs that you need for a successful clinic definitely has to start from the top, and that's your executive support. And we are very lucky. We have wonderful executive support from our medical director, our CEO, and everybody in the executive offices. So when you do a clinic of this magnitude, people have to be pulled away from their regular jobs. So they have to understand that sometimes the phone calls and the emails are going to have to wait because you're actually taking care of your community and other staff members, and it's hours that they're away from their normal assignments. So you have to have that executive support that understands that that it's going to take time to get through this. The people who become part of your vaccination team and clinic team, they need to be flexible, self-motivated, very, very good patient and customer skills are very helpful to keep people moving through, because they might have to wait a few minutes before they get in for their shot, but you want your team to be friendly and helpful. And so those people will also become your core team members who like to deal with people in their community. There needs to be at least 3 leaders, one from your executive staff, one from nursing, and one from pharmacy, and we work together. We do a lot of things that the rest of the crew don't know that we do, with tracking and data, and just making sure all the supplies are ready, the forms are ready to go. So you have to have those people who are doing all that behind the scenes work to make sure that everything's ready. And appropriate space. You're going to need a big space to be able to do this, especially if you're expecting 100 to 200 people coming in an area. You have to be able to let them sit down for 15 minutes, 6 feet apart, and keep everything moving. So a good open space is helpful. Next slide. So this is just our clinic job positions that we thought are the helpful, the leads, the registration team, the guides, the vaccinators. Of course, we like for them to at least have some skill in giving a shot. So that's RNs, LPNs, PharmDs, and certified medical assistants. So those are who we allow to do our shots. We think that during the day, that one person's going to have at least 40 people that they've given a shot to. And then that means that they also have 40 people that they've got to do the documentation on. If you have 40 people, it takes about an hour and a half with the template that we've set up to go back and document on everybody. And then our vaccination prep, one person to draw up a vaccine for every 100 people. So we found that once we got to 100 people in our clinics during the day, we needed to add a second person who would do medication prep. It also helps if you're given Moderna and Pfizer the same day to have 2 different people. That way you don't make as many, you prevent mistakes. Then we have 2 people in our check-in area, and they write down, they have the person check in, they track them for 15 minutes, but while they're in there, they make them their vaccination cards, and they already have the letters ready to mail out. So they know exactly when they're coming back, where, what time before they leave. And then you need to have a way to communicate if you were to need rapid response help. So we have that, and a telephone and an epi kit there in that area. Next slide. So these are our vaccination prep. Charles has been with us every clinic drawing up vaccines, and he's kept up with being able to provide for 4 nurses at a time giving shots. So he was really able to keep that. If you see the red and yellow box, they're marked Moderna and Pfizer. So we know if we're doing both types of shots the same day, we know which one that we need to grab. We also put the vaccine in 2 different size needles so that to prevent mistakes. The Moderna we put in a regular 3 ml syringe, and a Pfizer we put in a TB syringe. So we're trying to make sure we prevent any mistakes as best possible. Next slide. So we also, it got to the point that, like Chris was saying, your first few clinics are fine because you're normally only given one type of vaccine. They're your first dose. But when you start having your second dose people come back and you're trying to manipulate first dose and second dose and 2 different medications, the method that we came up with was to color code everything. So we color coded our paperwork for initial dose, first dose, and second dose, and then medications. So we used yellow paper for Pfizer, second dose, blue paper for Moderna, second dose, and white is their first dose. We've been getting more Moderna than anything else. So right now we're using Moderna as basically our first dose. The registration team looks at those schedules. That's why those computers are very important up front, to see which medication the patient got the first time, and they know which color paper to put on the clipboards that they send back with the patient. Always ask on those second dose people if they have their vaccination cards. If they have that, you document their second dose, but also you can verify which medicine they got the first time. And the bins for the separate syringes. And anytime you have new people coming into your vaccination area, you want to orient them to what your process is. Don't let them figure it out on their own. Make sure you have a good orientation for that. If you get a new delivery of medication from the pharmacy, make sure you check your lot numbers, that they're either the same or if the lot number has changed. And then now that needs to get to the vaccinators as well as the people who are filling out the vaccination cards. Next slide. Our infection control, always your PPE, everything that we normally do, disinfectant wipes, clean your surfaces, especially your high touch areas between patients. Those guides are good to help them make sure that they don't congregate. Have extra masks, because we have had a couple of people, either their mask broke or they didn't bring one. So go ahead and make sure that you've got extras, and don't overfill your needle boxes. Okay, your question was, do you have to get the same vaccine? Can you pop that up again on the chat?
Yes, that is her question. If you get the Pfizer or Moderna for the first dose, do you have to get the same manufacturer for the second dose?
So Chris researched that yesterday, and we'll let him answer that.
Yeah, what's been happening so far, which is extremely helpful, is if you receive a prime dose or first dose allocation, I'm not sure if IHS is doing or if it's further up the chain, but they're specifically holding a second dose of the same volume for you. So you should receive the same manufacturer. The CDC came out, I think it was last week or maybe earlier this week, you know, the what ifs. What if you run out of one manufacturer? What if a patient receives the other manufacturer for the second dose? Their recommendation is to treat that second dose. So say if you get first dose Pfizer and you get a second dose of Moderna, treat that as a complete series. You don't need to go in and revaccinate them. But I would try to minimize it if at all possible. If for no other reason, it's just going to throw your inventory numbers off to where, you know, it might have a trickle effect to others that are due their second dose of vaccine. So you can consider it a full series. If you started on Pfizer and there's just no more Pfizer to be had, you can complete the course with Moderna, but I would try to avoid it if you could.
Okay. So your clinic policy, you need to go ahead and have a good policy or plan or for your COVID vaccination clinic and include all the data. because if Joint Commission or anyone comes and asks for those, they will stop into your clinic and see how things are functioning. So you want to make sure that your policy is up to date, and if you make any changes, make sure to make them on your policy as well. You need to, if you're going to be vaccinating community as well as employees, you need to include the specifics of vaccinating each population. We use a signed standing order to give our Moderna and our Pfizer. The companies actually provided those, and then we had our medical director sign off on those. And so we've included that into our policy. Our clinic hours, we run from 9 a.m. to 12, and then we have lunch and 1 to 3. And you really can't do much later than 3 o'clock because those people have to do their documentation. And sometimes we have 2 different crews. We'll have a morning crew and an afternoon crew so that they can still do some of their regular work as well. Signage is important to direct your clients where they need to be, communicate your appointments. The front desk is, the operator is the one that's going to get a whole lot of the calls, so they need to know when you're having your clinics, where at, what times. So make sure that you communicate with everybody who might be getting those phone calls. And then your forms, you need your sign-in sheet, your vaccination sheet, your screening questionnaire. And then we keep a stack of paper on what to expect after vaccination, and Moderna provided a 2-page information sheet on their shot. So we keep that out there for the community and our any client that takes the vaccine to have for that, because they need to know the most common complaint that we've had is a sore arm, but they can get the chills, they can have some lymph node swelling, and that's normal reaction, and they need to know that is okay, and they can treat it symptomatically. Next slide. For your post-vaccination area, we set up tables. Well, our vaccination area has one way in, one way out. We have a total of 6 tables in the area. About 4 of those are for vaccinators. 2 of them are for the staff doing the medication prep. And then each nurse sets up her table the way she likes it. A phone is good so that we can reach out and let pharmacy know that we need more vaccine, or if someone were to have a need that we needed to call rapid response in that area, you need to have a phone. Then our post-injection area, they have a registration table with a sign-in form and a clock to be able to monitor time. And then there's a second person in there actually doing the scheduling and the appointment cards and actually putting in the letters to send out by the end of the day. And next slide. This is our vaccination area. 4 nurses. 3 of them there have been there for most every clinic. So they've dedicated a whole lot of time. We have a beautiful view, which the patients like, but we just keep them moving through that area. So in one door and out the other. And there's the foam cooler on the table, where that's what we keep over there to keep the vaccine in while we're drawing up the syringes. And you don't want to draw up vaccine more than an hour before use. You want to basically draw it up as you go. And there's our post-injection area with our sign-in crew and how we have our waiting area set up. They will leave with their card, and we keep them about 15 minutes, and then they're free to go. Anything else that we can answer that came to your minds?
I do have a quick question, but if anybody else has one, please go ahead of me, because I know you've got to hop off for another call. So we had heard from the area office that some tribes were having their informed consent process was backing things up. So we are working on a video that could maybe replace or supplement the informed consent process. We hopefully will have that out a week from Monday. So what we're envisioning is that video could be played. The patient could document and sign that they saw the video, and then document that they had the opportunity to ask questions of a nurse or somebody, and that they're consenting to it. Is that something that you all feel would be helpful to you guys?
I think that just like the flu shot or anything, one showing up is implied consent that they're there to get it. And we use the screening form as well. If the patient can sign the screening form and then the nurse sign after them, and then that's scanned into our system.
Okay.
So at intake, we have there's kind of a picture of it in there. We have a bigger space there as well. So I'm not really sure if that's the bottleneck in the process, is the informed consent and pre-vaccine paperwork for us, because there's a large space to actually house these patients socially distanced. And I'm curious, with a video, it might require some congregation in order to have more than just one person viewing it at a time. So I'm not sure. I think it might be one of those things that I have to see first to really have a good opinion on.
Well, and I believe the tribe that was having that bottleneck, it's because they were doing one-on-one informed consent in a patient room. And so it was really taking time. So, I mean, I don't think it's going to be useful for all tribes, but I kind of wanted to open that question to everyone to see if that would be something useful to them. Or it could even just be used to share educationally.
Right. The screening form is the part that slows us down, because if someone forgets their glasses, can't read, can't see it well enough. So our guides also help them fill out their forms. And we learned that after a couple of days with the community, because the nurse was having to stop and fill out the screening form for them. So once we got the guides to make sure that the forms were completed before they came back, that really sped things up.
And one thing I wanted to share that Nashville is doing about making sure that you're not wasting doses at the end of the day, especially with the booster and people not showing up. What you said, life happens. Nashville is doing something really cool at 2:30. That's what time they take their last shot. Every day they have a lottery, and you have to enter every day. And if they have any leftovers at the end of the day, you have to certify that you can be there within 30 minutes. They start calling that. I think for a smaller tribe, just a running list of people who would be interested. You don't have to go through the formality of entering a lottery, but I think that that's a great idea. I know one of the first days in Nashville, at the end of the day, they had some leftover doses. They ran across the street to the Subway shop and gave those extra doses out. So there's some innovative approaches out there for not wasting doses.
Yeah, we tend to just put on our running shoes and sprint through the hospital until we find enough victims for it. No, we're going to try our best to hold to our tiered approach, but if you have a couple doses left, it's much better in the arm of somebody not in that tier than it is in the trash can. So it is something that at the end of the day, we sort of have a bigger push to round up however many doses we have left, that many people.
And we always check with our inpatient unit to make sure there's nobody upstairs ready for discharge that we could vaccinate as well.
David, did your question get answered?
Yeah, huge thanks for sharing. Truly amazing and inspiring work. And once you get through the copperhead snakes and unpack the Russian dolls and start to actually draw doses, you mentioned the Vantage Point, the TB syringes for drawing. And then you also noted that you're using the 3 ml for the Moderna and then the TB syringes for the Pfizer. Are you seeing greater frequency of being an ability to be able to get the 11th dose using the 3 ml, or greater frequency with the TB syringes to get that extra 6 through Pfizer?
I don't know that I would bank on that 11th dose with any regularity. Yeah, and I was going to ask you about the second part of your question in the chat box there, just for some clarity on it. The 11th dose in Moderna is fleeting. It's not as I wouldn't make a point of trying to get that with any regularity. we have the 1 ml TB syringes right now. They do have more dead volume than like the Vanish Point or the Lure-Lock syringes. However, Lure-Lock syringes are tough to come by right now. So they get that 6th dose with less reliability. But know that a lot of the inventory tracking, like if we use VAMs, for instance, if you put in there that you received a vial of Pfizer, it's going to log you 5 doses of Pfizer. So I wouldn't like delay administration simply to have more efficient supplies in, because the amount of benefit that brings might not be worth the delay or cost of said delay. And, you know, I'm not exactly sure what the price of Vantage Point syringes are, but I'm sure they're more expensive than just the cheapo PPD syringes are. So, you know, it's the cherry on top when you get it. I think the more, I guess, the more interlocking syringe vaccine or syringe needle combos attain it more regularly. But, you know, use what you got and get started is probably my best piece of advice on that.
Awesome. Thank you. And apologies if I missed it, but are you able to source both from the state and IHS with the public health side and then IHS?
Yeah, I think, and y'all could probably speak to this better than I can, but I think as part of the agreement with IHS is that we would solely partner with them for sourcing a vaccine. So we do not pull vaccine from the state side, from North Carolina.
Thank you. And how much convincing did you have to do for Dr. Brown to come get his vaccine?
He wanted to be towards the front of the line. I'm sure he's very excited about this, but he's been a huge help for us. Like Janet was detailing, we have a little waiting area to monitor folks 15 minutes after vaccination. He was happy to volunteer in that role. Especially at the beginning when we didn't have as much experience with it. You know, the concern is you hear the news reports of people having anaphylactic type reactions because of it. And I think it's easy to say, well, if there's one, then everybody on earth is having anaphylactic type reactions with this, when really the odds aren't showing that. But it was really a benefit having him there. And you know, if we should need it, he was present on site. Thankfully, knock on wood, that has not been an issue here, but you know, better safe than sorry, I suppose.
Any other questions? Just a reminder to fill out the survey, and we're going to go to Christy real quick to speak on the Biden plan.
Thank you. That was very informative and actually very helpful, I think, to us epicenter folk. You know, we're often removed from the clinics and what's going on stepwise, and that really gives us some ideas about things that we can do to assist your vaccine efforts from the public health and epidemiological standpoint, and just helps me to understand the process much better. So thank you for that. And I'm looking forward to future presentations on this as well. I just wanted to give a very brief update. We are monitoring the new plan that was rolled out by the Biden administration. I read the executive summary last week. However, Monday or Tuesday, they rolled out a 200-page document. I am still wading through that. The EPI team is as well. 2 weeks ago, Chief Cook asked me about the release of the stockpile and was I confident that was happen. I sort of hedged that question and said, to the best of my knowledge, yes, it was going to happen. And I guess I was confident. And not an hour later, I had to eat my words when the news report came out that there was no real, that stockpile had already been dipped into in late December. So my apologies on that. But it does look like, I can tell you, we are going through the Biden plan. There is nothing particularly innovative in there. There is nothing that made any of us go, wow, that was a really great idea that we hadn't thought of before. But I will say it is a breath of fresh air that we have leadership, writing down, okay, here's what we need to do. Here are the steps that we need to take. And here is how that is going to happen. And I think that is huge and much needed right now. So, they're all just basic public health 101 steps for how to handle things. But it does appear to me, anyways, that this is now coming from the top down, and we do have some leadership on this issue. I don't know if anybody else has read through it or skimmed through it, if they have any comments to make on it. I was on a White House briefing call. ASTO was on it, NACHO was on it, and everybody is basically saying the same thing. This plan was very much needed. We need some leadership, some guidance on this. That does appear to be happening. I can't believe it's only been a week and a couple of days since he's been inaugurated. It feels like about 3 weeks, and I don't really know why that is. Kudos. It does seem to be picking up. Things do seem to be happening. But I would like to throw that out there about any support you guys may need. I know we did have some folks from the Nashville area office. We are communicating with them, so we can pass on any messages that you might have about support needs. Okay, as I said, we are looking at doing the informed consent script. I think that there are some tribes that might help. We can also see if that can be modified into an educational video. We've already created a series of videos, but that might be an additional one that can be played. So we do have that in the works.
Dr. Brown does have an announcement.
I'll turn it over to you, Dr. B. We may need to unmute him.
You're on mute, Dr. Brown. Okay, well, he's trying to unmute himself.
There he is. There he is.
Can you hear me now?
Yes.
Hello?
Yes, we can
So
hear
you
you.
can hear me okay?
Yes.
Good. Okay. So on the way to work this morning, I was listening to the radio, and they said that there would be a vaccine announcement, and I assumed it would be Johnson & Johnson, and it actually was Novavax. They have initial efficacy data on their phase 3 trial that's been going on in the United Kingdom. And it turns out that they have an 89.3% efficacy for their vaccine. That is really tremendous news because this particular vaccine is can be transported and stored for many months, if not years, at refrigerator temperatures, and it's even pretty stable at room temperature. So I'm hoping that they will apply for an EUA based on the UK data. There is a large phase 3 trial going on in the US, and I hope they don't wait for that. The other news is that Johnson & Johnson, their vaccine has efficacy data. The disappointing thing is that the one-shot regimen only had 66% efficacy. Although, and that we've gotten used to 94, 95%. So 89.3 doesn't sound quite as good, and 66 sounds abysmal. But you have to remember that most years the flu shot doesn't have 66% efficacy. It doesn't mean that it's useless. It just means it's maybe not quite as good. So there'll be a lot more in the next month, I think, on both these vaccines. So stand by.
Thank you, Dr. Brown. Just a reminder to fill out the survey. It will help us come up with new programming for you, and also help with the attendance. Christy, do you have something?
Yeah, we've lined up for 2 weeks from now, right? Did we confirm the speaker?
We have a
Just
night.
and that. Yeah, Oneida is also going to do a similar one of these lessons learned, their vaccine clinic. We thought that might be helpful for smaller communities that don't have the scale of Cherokee. So please tune in for that.
Yes, and that'll be in 2 weeks, February 12th. We have February 26th planned out, which is going to be Passamaquoddy Indian Township speaking on their vaccine distribution. And I believe that's as far as we've gotten. So tune into those. Thank you all for joining today. If y'all have any questions, you can ask them now. Otherwise, you can have a great rest of your day and good weekend. Bye.
Thank you.
Thank you.
Bye. Have a good week.